August 17th, 2018, and this is Lisa Salberg with the Hypertrophic Cardiomyopathy Association, and welcome to the HCMA official Facebook page. Today we have a very interesting conversation we're going to have with Dr. Milind Desai of the Cleveland Clinic, discussing a new article he has just published in JACC. Before we get started and introduce our guest, I just want to go over some housekeeping rules. At the end of this interview, we're going to have a Q&A session. I remind you to keep your questions to the article that's being presented and HCM in general. We are not able to provide individual consults via Facebook, obviously. If you would like to contact Dr. Desai after the broadcast, I encourage you to go to the HCMA website, look at our directory listings for the Cleveland Clinic, and he will be able to be contacted through that source. So again, thanks for joining Dr. Desai, and welcome to the HCMA Facebook page.
Thank you for providing me with the opportunity to talk to you and the folks on the HCMA website, and to the patients and family members who are on the website. Thank you again for joining us. Hopefully this should be educational and informative session.
I hope so too. So within the last couple of days, you sent me a new article that you published, and I got a little excited about it because I think it really is going to help our patient population. The title of the article is Late Gadolinium Enhancement in Patients with Hypertrophic Cardiomyopathy and Preserved Systolic Function. I'd like you to explain a little bit about the title and the methods and what we're looking at here and why this might be a little bit of a game changer.
So thank you again. So basically, for patients suffering from hypertrophic cardiomyopathy, one of the things that we are worried about is their slightly increased risk of sudden cardiac death because of various predispositions. The muscle is thick, the muscle fibers are not arranged appropriately, and there is a lot of fibrosis or scar tissue buildup. And all these things predispose patients to arrhythmias. So the holy grail in hypertrophic cardiomyopathy has been to risk stratify patients that are, and identify patients that are at an increased risk of sudden cardiac death. Basically, American Heart Association and American College of Cardiology, researchers working alongside them have identified various risk factors that identify predisposed individuals. Similarly, folks on the other side of the Atlantic in Europe have also come up with an ESC, European Society of Cardiology risk calculator, which uses the standard known risk factors in hypertrophic cardiomyopathy to come up with a score. Bottom line is both sides of the pond, they want to identify patients, some of you, who may be at an increased risk for sudden cardiac death. Doing so would help identify a group of patients that we can put in a defibrillator and prophylactically prevent sudden cardiac death. So with that background, there's obviously recognition that some of these risk factors they are not perfect. Nothing in life is perfect, and they may under-identify some individuals or over-identify in some groups. So there is a need for refinement of these criteria and improved risk stratification. Since we started using MRIs, and I'm sure many of you have had MRIs in the past, we have recognized that patients with hypertrophic cardiomyopathy have significantly increased incidence of scar formation or fibrosis in their heart. And MRI is extremely good at identifying fibrosis. It is very accurate, non-invasive way of identifying fibrosis to a point where we can even quantify fibrosis. And studies in the past have shown that you can not only quantify fibrosis, and you can identify patients who may be at an increased risk. So big picture, our thought process was to look at our patient population where we have done MRIs. You know, I did not want to take all comers. The big picture was we wanted to take people where the biggest bang for the buck would be in terms of risk stratification. So, you know, if you have low ejection fraction, if your heart function is low, you are already on the bad slippery slope of where your event rate is significantly increased. So first and foremost, we excluded those patients because they're the horses out of the barn. Lisa would know about the horse in the barn. The horse is out of the barn, and we need to take care of you in a very aggressive, different way. Compare that. So that's why all the patients that we included in this study had normal function. The other thing is, all these risk factors, the standard risk factors, the traditional risk factors, they try to identify patients who are at an extremely high risk, where there's not much conversation. You go ahead and put a defibrillator in, otherwise they are at an increased risk of sudden cardiac death. So the fundamental thing we did was we identified patients that were low and intermediate risk for sudden cardiac death. This is where I would imagine we conceptualized that the bang for the buck would be the biggest. And those were, we studied about 1,400, over 1,400 patients, so 1,423 patients who were evaluated at the Cleveland Clinic, who underwent your standard echo. Some of them also underwent stress echo, and all of them, obviously, by study design, underwent cardiac MRI, including assessment of late So every one of these patients got gadolinium, and then as part of their standard image acquisition, we wait after giving 10 minutes after giving gadolinium, we re-image them to look for fibrosis or scar tissue. Then we went ahead and quantified the scar tissue. And again, quantification, it's sort of, you have to adjust the thresholds, because if you have a low threshold for detection, then you'll be more sensitive, meaning you'll identify more people than what needs to be identified. So we established some ground rules at the outset that we were going to utilize certain thresholds, only above which, if you fall above that threshold, only then we would call it scar. And then we quantified that in each and every patient. And we also recorded downstream events, how many patients had surgery, how many were obstructive, how many were non-obstructive, and then how many had downstream events, including who had defibrillators, who had shocks, and who unfortunately died over a period of. And this study, basically, we've been doing MRIs in earnest since about 2006, 2007. So, where everybody, we offer them an MRI, and basically we recruited such consecutive patients, 1,423. And so our mean follow-up is about 4.7. So give or take about 5 years is the mean follow-up. And thankfully, out of 1,400 patients, only 60 or 4% patients had events. So you can look at glass half empty or glass half full. The glass half full is we are doing good in managing these patients, where in a span of 5 years, only 4% patients had a major event. So we have come a very long way. The other thing we did about this paper was, not every HCM patient is the same. There's some that you can provoke the heck out of them and they do not have a gradient. Then there's some who have a gradient, some who need surgery, some who are treated with medications. And you cannot lump them all together. We already are beginning to know that their outcomes are different in different groups. So the other thing we did was we not only studied the outcomes in the entire group, but we also subdivided them into obstructive group and non-obstructive group. And even within the obstructive group, we wanted to see how myectomy, surgical myectomy, helps modulate outcomes. And as some of you know, or many of you may know, at Cleveland Clinic, we know a thing or two about how to not only take care of HCM patients, but also operate on them and relieve their obstruction. We have a large program related to that. So basically, more than 900 patients had obstruction, of which about almost 700, so 686 that were included in this group had a surgical myectomy. Ta-da! Big picture, what we found was, using quantification, we were able to identify a threshold of 15% scar. So if you take your entire heart muscle on the left side and identify normal versus abnormal, meaning scar, beyond a certain threshold. And what we found was, if your scar is more than 15% of your entire left-sided heart muscle mass, then your risk of a downstream event, death or sudden death or defibrillator firing is significantly higher compared to less than 15%.
Let's pause here for one.
Yeah.
You're giving an awful lot of information, and I'm going to package some of it.
Yes.
So looked at 1,400 patients
Yeah.
who had MRIs.
Yes.
You narrowed them down to those with preserved EFs,
Yes.
those who have some degree of scar or burst or not scar, and you looked at these different subgroups of people.
Yes.
And we've compared them to the known risk factors, both in the USA guidelines and the ESC guidelines, which differ slightly.
Yes.
And now we're at a point to say, what do these people actually do differently based upon their scar burden, whether or not it's related to being obstructed or non-obstructed or any of the other factors that we know?
Yes.
Would that be a good Reader's Digest version of what we've just discussed?
Yes, I think so. So to carry on further, so basically what we did was we did not look at the scar on itself. We stacked it on what we know are reasonably good risk factor prediction tools on both sides of the Atlantic. And what we were able to show that addition of scar to these models adds incremental value to predicting future events. So that is, and not only did that do it in the entire population, we were able to show it in all the subgroups. So obstructive subgroup, non-obstructive subgroup. What we also further showed that, so, and you can put up the pictures, Lisa, the graphs.
So here we have, and I'm going to try to make this bigger for everybody. It's a first time.
We can start with the central figure first.
Nope, let me get it to the right size. That's bigger. And then let me make it a little bit larger so you can see it better. Oh, you want the central first, I'm sorry. We'll scroll on down to that.
Yes.
And I have to make that a little smaller.
Yes.
Okay.
So these are, survival curves. These are standard survival curves. So let's look at the figure on the top left. It's in the non-obstructive group. Let me just make sure I'm saying the right thing. Yes.
Yep.
It is in the non-obstructive group. Again, patients were divided into two subgroups, those with higher than 15% scar, those without. Needless to say, the lower line represents the folks with higher scar burden, and they less proportion survived. The same findings were noted in obstructive group, which is the top right. Now look at the bottom right. We were able to show that even in a myectomy population, we were able to separate based on scar. Now, the most important figure, I think, is figure C. If we took only the obstructive patients in figure C, and we divided them into four subgroups. Ones that had myectomy and less than 15% scar, the others myectomy, more than 15% scar, and so on and so forth. And the other one with high scar burden and no myectomy. What we were able to show that people who did not have a myectomy but had a higher scar burden had the worst longer term outcomes, which means there is a possibility that myectomy can modulate not only your obstruction, but also potentially your survival and your arrhythmia risk. Now you can go to the second figure, which is, I think, also very interesting.
Okay, there we go.
And this figure, again, what this is, these are fancy, what we call spline curves. Nobody has to know this, what exactly they are, but what they show is they give a good visual. So the figure A suggests that it looks at survival at about 5 years, freedom from events. So what we were able to show is that there is about a 15 to 20% cutoff beyond which the risk of events increases dramatically or significantly. I want the viewers to focus also on figure B and figure C, where the same findings were noted in obstructive as well as non-obstructive groups. But a crucial finding which we noted, which sort of I had a sense but never been proven before, is look at figure D. That is only the myectomy population. Here, the curves go up. They go upwards, not at 15% cutoff, but at 25% cutoff, which means if you are somebody undergoing myectomy, what does myectomy do? It debulks the bad muscle. It gets rid of the bad, thicker muscle from your heart. So if you have a myectomy, then the amount of scar you need to actually have a bad impact on you is 25%, much higher. So in other words, myectomy not only makes you feel better by relieving obstruction, takes away your shortness of breath, potentially it can modulate your risk for a future event. To me, I think this is a very important finding of this paper. Lisa.
Wow. Okay, that was an awful lot of information. I'm going to take down the graph now so we can have a bit of a more in-depth conversation here. And what I think is critical to talk about here is about, 8-9 years ago, Marty Marin and the team at Tufts published another paper. Actually, no, it was like 2012-13 because it was after the guidelines went out. And that was the first indicator that we saw LGE risk was potentially a risk factor for sudden death. In the guidelines, it was a too early to tell piece. So that was 2011. So we were looking at this 2010-11, not enough data yet. Shortly thereafter, Marty Marin and team came up with the data that said, LGE seems bad. We think it's 15% or more, and that's an issue. Now we have this study from another center, 1,000 people, and we're validating yet again that 15 to 20% looks like the risk. So, number one, when we revisit the guidelines, would you vote in favor of adding LGE as an official risk factor for sudden cardiac arrest? Yes or no?
You're asking me or the audience? The answer is yes from me. Absolutely. I think, and Lisa, I think some patients, and of course I know you are aware of it, and many of the patients are also aware, there's something else coming down the pike, a large NIH, National Institute of Health, government-sponsored study, HCMR, which is essentially also where we have taken almost 2,800 patients from 40 sites across USA and North America and Europe. And that study is measuring all kinds of fancy things, including LGE, and it is accruing events. So my expectation is in the next 3 to 4 years, we'll have results trickling in from there. And I have no doubt that it is very likely going to validate the findings of our study as well as the previous study. The cutoffs, cutoffs may be slightly different, who knows, but the big picture of does LGE add incremental value in assessing risk, I think, should be validated. So these there's lots of exciting new things are happening in HCM. But to short answer, is there something in LGE and MRI for risk stratification to potentially influence the guideline? You darn right there is.
Now I'm going to delve into a conversation that's a little bit more controversial, because I think everybody in the community agrees that LGE is important. We just need to continue to validate it so that, and let's be clear, when we do these types of studies, there are a number of reasons why we do them. One of those reasons is to let payers know that there is a reason why we're doing these tests. There's a reason why they're paying for MRIs on a regular basis, because we're using them to determine risk and in the total picture, lowering healthcare costs and burden. Because we know you're at risk, we can give you an ICD, protect you from sudden death, treat you more aggressively if need be, rather than having to catch you after you've had a cardiac arrest and might have neuro injuries, et cetera, et cetera. So this is, being cost effective and being cautious about how we're utilizing healthcare. Now, before we get into the myectomy question, we are going to have to answer another question about MRI and LGE, and that is the frequency in which we need to repeat the MRI. And this is a question I get often here at the HCMA. I had an MRI 2 years ago. Is it time to go back? What do you think we're going to work out, or do you have an opinion at this time? How often should somebody be getting an MRI?
So this is strictly my opinion and belief. There's obviously not much data out there about frequency of MRIs, but I would say if you are a patient with hypertrophic cardio or maybe mild form of HCM, or you are genotype positive but you are not demonstrating the standard features of HCM, that patient, I tell them to come back in about 3 to 5 years. Most patients end up at my doorstep again at 3 years. They cannot wait, and they are there at 3 years. So there is some preliminary data I've seen from the London group about progression of LGE, and I think the mean time of follow-up, from what I recall, was about 4 or 5 years. So what I tell patients is, if you had an MRI and it did not show scar, or it showed only minimum amount of scar, then perhaps it's not a bad idea to revisit this in 3 to 5 years. That's what I tell patients. That's how I discuss it with them. Is there something set in stone? The answer is no, not that I'm aware of.
Okay.
And the other important thing we have to realize, there is also this data about gadolinium, and you can open TV and you may see all these lawyer commercials about gadolinium and this and that. So everything has to be balanced, and you cannot, repeating frequently all kinds of testing can have some downstream issues that we have to be always aware of. So I will throw that out also.
And I will punctuate that with the fact that if you're going to get an MRI for HCM, I cannot tell you strongly enough how I feel it is important to go to a high volume center of excellence where they have a specific HCM protocol in place for doing your MRI.
Yeah.
We give you an MRI and it's done in a program that doesn't have a great protocol, and they're not used to seeing this. They may not get the right images. You might not have the data you need to make decisions, and your insurance company is not going to pay for a second one.
Exactly.
So make sure if you think you're going to a center of excellence, make sure that's where your MRIs are done, because they're going to have the best protocols in place for that.
Yeah.
Now off to controversy land. So here we have more data saying myectomy changes outcome. There was some data a number of years ago published by our friends at the Mayo Clinic indicating that ICD discharge rates were lower in the post-myectomy population. We didn't exactly understand the why. This paper elucidates potentially one of the whys. We're getting rid of the scar. We're getting rid of bulk. We're getting rid of fibrosis potentially in the fact that we're getting a lower LGE rating. Should we be looking at myectomy differently? Should we be looking at it not only to make somebody wait for a myectomy until they're so symptomatic that they must have a myectomy? Should we be trying to get in front of that a little bit to improve quality of life, save them from getting very symptomatic, and potentially altering their risk score?
Yes, so like you said, this is a touchy-feely, controversial topic. And who better to tackle than you and me, Lisa?
I know, I like that.
So the way I look at it is as follows. First and foremost, I will preface anything I'm about to say is that what I say applies to an experienced team of providers in an experienced center. You cannot underscore the importance of this. If you want a good steak, you go to Morton's. You don't go to Golden Corral. I mean, not to throw anybody under the bus, but so that's I will start by saying that for sure. Having said that, if you are lucky enough to have access to an experienced center, a high volume center with experienced providers, then especially a multidisciplinary team of providers who can provide you with advanced imaging, advanced clinical care, advanced surgery, and in some cases, advanced alcohol septal ablation. Then I think it is a fair conversation to have about what the threshold would be to refer a patient for a myectomy. Now, currently the guidelines say you have to be in class 3 NYHA. What does class 3 NYHA mean? Significant reduction in your functional capacity. Okay, significant. You are dragging to the doctor's office because your quality of life is terrible. Now, I'm gonna sidetrack a little bit, okay, a little bit. The same group of guidelines, folks, when they look at patients with mitral regurgitation, mitral valve leak, okay? So if you have severe mitral valve leak, the same group of guideline writers say if you have severe mitral valve leak and if you are in the right center and right hands, right surgeon with 95% success rate and all that good stuff, you should never wait for symptoms. You should operate once you identify severe MR, severe mitral regurgitation. Okay, but now shift the conversation to hypertrophic cardiomyopathy. Oh my God, we cannot do that. I'm not insinuating we should be operating on asymptomatic individuals. But what we do, and many of my patients, our patients, if they are on or listening to this, we use a combination of symptom assessment as well as putting them on a treadmill. My favorite quote is, let the rubber meet the road. Okay, I want you to run on a treadmill. I want to see how much you can do. If you are a 45-year-old man, I want to see whether or not you hit the targets that I would expect from a 45-year-old man. And if your capacity is like a 75-year-old grandma, and you have a gradient of 200 or what have you, and you are feeling dizzy or short of breath at peak exercise, I think you got issues. We would try with medications, but when you are 40 years old and trying to take your 200 milligrams of Toprol XL or 480 milligrams of verapamil, there's a possibility of you having side effects that affect your quality of life. Maybe you are not at NYHA class 3, but you are at NYHA class 2 at that level with a grossly abnormal stress test. To me, if you are at the Cleveland Clinic and if I have the backup of my surgeons, the quality of surgeons I have, I would not have too much of a hesitation for at least bringing up surgery, what I like to call the S word, with the patients, and we make a shared decision, an informed decision in that context. So, and we have data. We have previous published paper that combination of symptom assessment and stress testing in obstructive cardiomyopathy patients to decide about timing of surgery, surgical myectomy. In that group, surgery folks did far better in a 7 or 8 year follow-up compared to the non-surgical groups. So, our take on that is slightly different and compared to the rest of the crowd.
So I'm going to leave that one as jury out. Great conversation in terms of where is the line for myectomy. I do believe at this point the HCMA still stands as the #1 referrer both to your program, Mayo Tufts, in terms of outside referrers for myectomy. So we see a lot of the same people. And in that, there are certain anatomies that really do lend themselves very well to myectomy, and these people have wonderful outcomes. And there are a number of people that are on this chat right now who I know were some of those people. And I just want people to know that, open heart surgery, yes, it's scary, and nobody wants to have open heart surgery. But the improvements in quality of life, and now potentially the changes in risk stratification, might be worth a second look if you've been on the fence and aren't sure if you should do it or not. I mean, I'm actually wearing a shirt today where you can see my thoracotomy scar from my transplant. Was it fun to have my chest cracked open? No. But it's not the worst thing in the world, honestly. My back pain was worse than my thoracotomy pain from a previous back injury. So it's all about making sense out of what's best for you long term. So have the conversations, go to a high volume center. The HCMA is working with surgeons around the country to develop proctorships and best practices between the high volumes and the lower volume programs, so that we can work around the country to elevate the knowledge of how to do myectomy well and make sure patients have access. For right now, some people still may have to travel, but hopefully in another 8 to 10 years, it'll be more accessible in your local community. So we'll talk more about that later. We do have one question coming in from Pam, and she wants to know if there are cases where there's just too much buildup of muscle to eliminate, that eliminates the possibility of myectomy. So have you ever seen a heart too thick to respond to myectomy?
So from a surgeon's perspective, let's assume that someone like me decides that this person would benefit from a myectomy. More muscle is good, meaning he gets to chop more out, shave more out. Okay, so that, but there could be some scenarios where more muscle, this is diseased muscle, which creates what you call a pattern of restrictive cardiomyopathy. And what is restrictive cardiomyopathy? Meaning the heart muscle is thick, but it is diseased and it is not pumping enough blood. We can try myectomy in those cases, but often what happens is it is sort of like trying to flog a dead horse to doing more, and your output, your significant improvement may not happen. Now, we and some other centers are doing what is called an extensive debulking myectomy to help improve the function and the pumping chamber, pumping of the heart, to improve what is called the stroke volume of the heart. And we have had some good results. Unfortunately, in some of these patients, or at least traditionally, if you get to a point of advanced restrictive cardiomyopathy, you end up needing a transplant. And as of right now, I'm seeing a lady in red who just went through that process, called Lisa Salberg. So, she's a perfect example of where the judgment was that a debulking myectomy would not have helped her.
Right.
And she needed a transplant.
And I had a biopsy yesterday. And my center called to give me my biopsy results while we were live. So I have to call them back and see if my biopsy is. So you don't get rid of cardiac issues when you have a transplant. You exchange one set of problems for another. They're different. Quality of life is better, but risks are still quite high. Okay, so we have a couple of other questions coming in. Sometimes these questions take up the whole screen. What is the best way to appeal insurance after MRI was denied? Last one was approximately 7 years ago at the Cleveland Clinic. Could there be more scar in that time? Renee, I'm going to give you a couple of things to think about there. Number one, we offer a service at the HCMA for members. It takes us a little bit of time, so we can't do this for all comers. You have to be a paid member. We can help you write an appeal letter, and we write really scary appeal letters that are loaded with things called facts. I know facts is a weird word these days, but we will put in copies of this article and other articles that validate the utilization of MRI. But we will also look at your individualized case and work with you and your physician to explain why it's important for you. So we can help you with that appeal. Milind, do you have any comments on how to appeal that?
Yeah, I mean, often what happens is if you are hitting a dead end, most of the experienced high volume centers, they have dedicated financial counselors who will work with them. Often they can't get to it. And I mean, I picked up the phone and had a conversation with the insurance company. My colleagues, my partners, they do that also. I will tell you, one of the advantages of working at a place like this is when I'm having a conversation with this insurance company guy who's given me a tutorial on why he thinks it is not, coding some of your own papers, it works. Often, the insurance guys, they sort of, back down a little bit. So, it is a hit or a miss, I will tell you, but don't lose hope. Always engage your doctor. Have a conversation, and in the case of hypertrophic cardiomyopathy, Lisa and HCMA is such a huge resource that they will do a lot of your work for you.
That we can. That's what we're here for. Okay, some other questions. Pam's back with another question. In her case, her septal thickness is 3.5. I do not think that would be a hindrance for myectomy. I've known people with measurements of up to 4.3 who've gone for myectomy and had successful myectomy, and they can do well. Another question, Dwayne, what are your thoughts on lisinopril prescribed after myectomy? That gets into individualized treatment discussions, and I don't think we can really go too far there other than to say there is a role for lisinopril in some people with non-obstructed HCM.
Yeah, agreed. So, so if your muscle has been debulked and your obstruction is relieved, then there, like Lisa mentioned, there is potential for ACE inhibitors or ARBs. Lisinopril is an ACE inhibitor where it could modulate your outcomes by affecting your fibrosis, etc. But also, HCM patients don't live in an isolated bubble. They get older, they develop diabetes, they have high blood pressure, they gain some weight, they can develop coronary artery disease, and all these things lead to potentially the need for other therapies and individualized discussions. So I would not use a blanket statement, but I would have individualized decision making, especially in your case.
Okay, we have one more question, and I'm going to tell you right now, we can't get very specific here, but we'll handle this in a general term. Somebody says that their septum was 0.8 in 2005, now 1.4. Should you be concerned? Well, that's moving into a clinical diagnosis of HCM in a family with HCM, so we want to follow that more carefully. And the last echo showing a dilated atrium, which is a common feature in hypertrophic cardiomyopathy. Do you need to go to a COE? And you're asking for your son, you're having a myectomy in Grand Rapids on Monday. This is a thing that I would bring up with your team in Grand Rapids, and I would bring your son's echo with you and let them take a look at it. It does sound like he's moving towards an HCM state. I would look at genetic testing. If he's a gene carrier, items are present, that would tell us that there's probably something else going on there. Dr. Desai, any comments?
And the other thing, at the end of the day, I'm still fairly old-fashioned in my thinking. I like to trust but verify. So the 0.8 versus 1.4, I would like to have a look at it, like an experienced person, look at the old and the new, compare them. Very often, what we end up finding is that the measurements are performed a little carelessly, and the difference between this and that could just be explained by errors in measurements. I'm not saying that's the case here, but always trust but verify. At least that's what Ronald Reagan taught us. So.
Okay, I didn't know we were going to be invoking Reagan, but that's okay. So I want to just summarize a couple of things, and we're going to wrap up here in just a second. So I really thought that this paper was validation of things that we had been thinking for a long time, and I really do appreciate the work that you and your team put into collecting this amount of data. It's really important that we have these big data pools to work from, because it gives us more understanding of what's really happening. So thank you and your team for doing this hard work. And thank you to all of the people who signed that little form that said, my MRI can be used for research. This is what you did it for. So thank you to the 1,000 of you plus that signed that form, and we were able to use this. So that's number one. Charles, I didn't see your question. I'm so sorry. I'm sorry, there's another question. We'll go back. Thank you for saying that, Charles, because I did miss it. So high LGE in the absence of other known risks equals recommendation for ICD, yes or no?
So this is where this is a very good question. This is where we are getting into challenging the guidelines. So as of right now, the American guidelines utilize LGE as a modifier of risk in the setting of other established risk factors. So when you are on a fence, and if you see, when you're on a fence with standard risk factors and you see LGE, high LGE, then it should lead you towards an ICD. The European guidelines, unfortunately, don't take that into account, or they downplay the role of MRI. So clearly there's controversy, but I will tell you, if you are in my office and you have you have documented hypertrophic cardiomyopathy, and your scar burden is 25-30%, before I sure as heck am going to look at the Holter, or I'm going to give you a longer term monitor to make sure you're not having any arrhythmias. In fact, what I've been doing is also have you have a conversation, an intelligent conversation with one of my colleagues in electrophysiology. This would be a shared decision making, but I'm not giving you a direct answer because there are no direct answers with this. But our hope is that the studies that we are doing and the NIH study will push us towards sort of making a little bit more firmer recommendations with regards to LGE and ICD.
Okay. I pulled up another article that I was kind of going through real quickly, and I'm just going to bring it up to the broadcast for a second, because it's mentioned in here as well. And this is Dr. Barry Marin writing on the contemporary natural history and management of non-obstructive HCM. And I bring this article up because he talks a little bit in here about the utilization of MRI and how important it is. But again, we still haven't quite gotten to is it a full-blown risk factor or not?
Yeah.
But again, our patron saint of hypertrophic cardiomyopathy research, Barry Marin, he's on the same camp too. So this isn't controversial in terms of do people believe in MRI or not. People believe in it. It's just how to use that data to exactly extrapolate to risk. I think we're there, but not quite yet. I think we just have maybe another year or two to go of massaging the data and looking at it really closely before it's going to get it's an independent risk factor thumbs up. But for right now, if your LGE is over 15%, this is a conversation you need to have with your individual care provider and look at the rest of your, situation, look at your family history, look at everything very clearly, very soberly, and make a decision that fits you and your family the best. That would be my recommendation.
And honestly, Lisa said something very important here that should not be missed. Just because you have LGE, a few specks of LGE does not require that you get an ICD, right? In fact, in our study, in the NIH study, I know that almost half, in some cases, more than 50% of people will have some degree of LGE. So as soon as
stop there for 1 second, Milind. Somebody asked a question because we did answer it early in the talk. LGE, late gadolinium enhancement. When you have an MRI, they give you an IV injection of gadolinium. Gadolinium has this way of being uptaken into the heart, and the myocardium will show as black on your MRI, and the scarring or fibrosis will show as white, and scar in a muscle, not good. So more LGE is bad.
Yeah, perfect. So, we in our studies, in other previous studies, even the NIH data, what we are seeing is almost 50%, in some cases even higher, patients will have some form of LGE. So just because you have LGE does not mean you go and get yourself a defibrillator. That's why I think these thresholds need to be identified. And maybe, I'll be the first one to admit, 15%, who knows, maybe a slightly different risk population, that threshold may be higher or lower. But either way, some sort of quantification and thresholding should be considered when you are having this conversation.
So in review, MRIs have a very big role in HCM because they can identify anatomy more specifically than echo.
Mm-hmm.
They can identify scar. They can be used longitudinally to do follow-ups to see if scar is progressing or anatomy is changing. And we can potentially look forward to using the data collected from an MRI to help us identify risk factors in those who might be at a higher risk for sudden cardiac arrest than we previously had data enough to determine. Secondarily, we looked at myectomy, and myectomy in the population that we're talking about with MRI, actually those who've had myectomy had a better long-term outcome than those who didn't have myectomy when compared head to head in terms of their amount of LGE and scarring present.
Yeah.
Would that be a good
I think so.
message?
I think so. That was a very good summary. Yep.
Well, thank you. I've been studying this stuff. I want to thank Dr. Desai for taking the time to talk to us today. It was really something that I wanted to get done very quickly because this article just came out. It is published on the HCMA website. I put it up there this morning. I'll massage it a little bit more and make it look a little prettier in the coming days. It'll be the same link. But if you go into articles of interest on the sidebar of the website, the link will be right there. I will post it into this talk when we're done. And you can look at the article yourself. And if you want to contact Dr. Desai or be evaluated by Cleveland Clinic or any one of the HCMA recognized centers of excellence in the country, please go to our website and you can look up over 30 programs and 3 more are sitting on my couch waiting for board approval. So we'll be 34 programs by the end of the year at least. So please check out that list. If you've not been evaluated by an HCMA specialist, please get to that list and get to a COE. It might just change your life.
Yeah.
Dr. Desai, thank you for sharing your time today. We really do appreciate it, and thank you for the hard work on behalf of the community.
Thank you very much for having me on, and hopefully this was worth everybody's time, and we learned something. I think, I learned everything from the patients. Every single research paper I've written, the idea has come from a patient interaction. So, I'm always eternally grateful for that.
And we're grateful that you listen. Thank you very much.
Thank you.
Have a great day, everybody. Bye-bye.
Everybody, have a nice day. Bye. Thanks.